part of the session. It is my pleasure to present Professor Dr. Manal Halim, Professor of Radiology, Cairo University. She's always been there in all our joint conferences with the urology department in Cairo University, and she's always been active in participating and arranging all the workshops between our both departments. So I am happy to present Dr. Manal for the next presentation.
Good morning, everybody. Good morning, the dear colleagues. Good morning, the good chairman. Today we're our most important, our session was the screening, and now we'll go a little bit to get more. And so today I'll talk about the role of PSMA in detection of prostate cancer biochemical recurrence after treatments. At first, we're going to start with the basic information. What's a PET-CT? PET-CT is a positron emission tomography combined with a computed tomography, CT, and so we gain from this the anatomical information from the CT plus the functional imaging from the PET imaging. And here is the way the images goes for us. It's where is the PET data and then the CT data, and then both of them that are fused together, fused PET and CT data. The PET-CT need a radiotracer, and the most common radiotracer is the 18-fluorine fluorodeoxyglucose, which is injected into the patient and localize the areas of high glucose uptake or metabolism. And the assessment of the radiotracer is easy by first visual inspection. I mean, this is the PET image, and this is the CT image, and this is the fused image. So a visual inspection will get us to see the high uptake of the tracer. And the second way of assessment is the standardized uptake value, SUV. It's used for assessment of the amount of fluorodeoxyglucose activity per tissue volume. SUV in malignant tissues is about 2.5 to 3 or more, and there is normal tissues like the liver, lung, and that of the marrow range from 0.5 to 2.5. The SUV is influenced by fluorodeoxyglucose, by the patient weight, by interval between fluorodeoxyglucose injection and scanning, and by the blood glucose level, and of course it varies from different scanners and manufacturers. And these changes can make it minimized with standardized protocols and quality control. And then the patient is scanned. It's easy to scan the PET scan. First, the patient fasts for 4 to 6 hours, and we measure the blood glucose. It should be less than 180 milligram per dl. Fluorodeoxy dose is 5.2, and there is no contraindication for the fluorodeoxyglucose. And we decrease the physical activity and the speech of the patient and empty his bladder before the scan, and then start the scan after injection by 60 minutes later. And the scanning technique is still easy. First, we take the CT scans in scouts. In a scout is from above, from the mandible to the thigh, and the scout takes about 1 minute. CT scan takes about 1 minute in a quiet respiration. And then the PET is taken in the same field of view, but 6 to 7 overlapping bed positions are planned, 5 to 7 minutes acquisition in quiet respiration. Physiological of the 18 fluorodeoxyglucose, normally it's excreted in the collecting system and renal bladder, and that's their appearance on the PET scan. And of course, it's excreted into the renal bladder, and here as it is in the urinary bladder. And now, an overview for prostate cancer. Over the world, males all ages, prostate cancer is the second incidence, equals 14%, and 5th cause of death. In Egypt, it's the 4th incidence, cancer, and the 4th cause of death in Egypt. When prostate cancer detection early, as Professor Yali and Professor Padani told us, it has more than 90% cure rates, and that's why for the screening program. Another key issue of this tumor is to detect the recurrent disease after treatments. Although PSA is a sensitive indicator of disease recurrence, it's critical to differentiate between local and systemic recurrence. في حاجة يا جماعة IT في حاجة لو تسمحوا هدوء شوية لو تسمحوا. To date, this is a major challenge for all conventional imaging modalities. I mean dynamic contrast enhancement, CT, MRI, or transrectal ultrasound. The diagnostic limitation of conventional imaging modalities have promoted the adoption of PET scan. PET scan revealed that he can shorten the way between the clinical biochemical recurrence and that of the clinical recurrence. It shortened the way, so it can see the disease early recurrence before the conventional imaging. 18-fluorodeoxyglucose is useful in solid cancer, yet not used routinely to diagnose early stage of prostate cancer due to low metabolism of most prostate cancer. 18-fluorodeoxyglucose PET uptake correlate with elevated PSA level and is useful in detecting bone and soft tissue metastasis from prostate cancer, but still have a lot of limitation. First, detection of the primary organ confined prostate cancer. 2, detection of local cancer after radical prostatectomy. I mean, there is difficulty to differentiate between post-operative scar and that of local recurrence. 3, detection of local cancer after radiotherapy. What's a PSMA? Let's start from the beginning. What's a PSMA? PSMA is a prostate-specific membrane antigen. It's a transmembrane glycoprotein overexpressed on prostate cancer cells. And so, this PSMA, it increases with tumor aggressiveness, with androgen independence, with metastatic disease, and with disease recurrence. Gallium-68 PSMA imaging is a recent advancement in the management of prostate cancer. What's the advantage of PSMA? PSMA PET present prostate cancer with excellent contrasts and high detection rate, even when the level of PSA is low. PSMA PET has promising potential for restaging in the biochemical recurrence after definite treatment of prostate cancer. 32% of the patients received radical treatment of localized prostate cancer may suffer from biochemical recurrence within 10 years. Now the question will be, what's the biochemical recurrence? What's the definition of biochemical recurrence? Biochemical recurrence is blood PSA level of 0.2 nanogram per milli or above with a second confirmed increase. This is considered biochemical recurrence following radical prostatectomy. And still, the definition is is after radical radiation therapy, a PSA level increase of 2 nanogram per milli over the nadir is considered a biochemical recurrence. There is a significant risk for disease relapse, which is usually detected by rising PSA level. At low PSA levels, conventional imaging has a limited ability to detect recurrent disease and therefore is not recommended. Very high sensitivity of PSMA PET-CT in the setting of biochemical recurrence, even in patients with low PSA levels. Detection rates are significantly superior to those of conventional imaging. In meta-analysis and detection rate, they found that the gallium PSA has the advantage of high detection rate at low PSA levels in the setting of biochemical recurrence. PSA level of 0 to 0.19 and from 0.2 to 1 nanogram per milli and 1 to 1.99 and over 2 were 42%, 58%, 76%, and 95% respective detection. While using the fluorine 18 also has a high detection for biochemical recurrence after radical prostatectomy, and it is even in low and ultra low PSA at 0.5 and 1 and 0.2, 0.5 nanogram per milli, detection rate were 74 and 61% respectively. And here is a table to show the different radiotracer used with PSMA, the 11 carbon and the fluorine 18 and the 68 gallon, and the half-life of the fluorine 18 is 110 minutes, and it's originated from the cyclone, and it's excreted in the urinary bladder as that of the gallium. And that's why there is now a shift today from 68 gallium locules toward the 18 fluorine labeled compounds. Image spatial resolution with 68 gallium is lower than that of 18 fluorine. Lower urinary excretion of 18 fluorine allow better assessment of local recurrence at prostatic bed or lymph node metastasis along the ureters. Because 18 fluorine has a longer half-life, it can be used in delayed imaging techniques. Let's see some cases to understand. This is a 70-year-old male patient with history of prostate cancer treated with radiation therapy 6 years ago. Now there is an elevated PSA level of 13.2. And the 18 fluorine PSMA was injected, and the patient shows This is his CT cuts. This is the PET scans. And here is the fusion scans. And the axial CT cuts in the same field of view show there is a high uptake with the fluorine PSMA level at the level of the peripheral zone of the mid gland with SUV maximum of 3.5. While on the pelvic scans of the same patient, CT scan and PET scan, and this is the fuse scan, another finding is found with high activity, very small sub-centimetric left-sided external iliac lymph node was seen. And when doing the bone scan for the patient and the level of the pelvis, the CT revealed we cannot see anything, but here there is high uptake of PSMA is seen at the femoral head, which is responding to metastasis of the sclerotic bone metastasis of the femoral head. Another case, this is a 73-year-old patient with history of prostate cancer treated by radical prostatectomy at 2014. He came for follow-up at 2016 by fluorodeoxyglucose. The PSA at this level was 0 nanogram per milli, and he was injected the fluorodeoxyglucose, and his first first PET scan revealed nothing. Nothing in the prostate, the local area, nothing in the nodes, nothing in the bones. And the patient returned back in 2021. And now his PSA level is 5.6 nanogram per milli. And follow up by 18 fluorine PSMA level revealed this way. It shows that this is his CT, this is his fused images, and this is the PET scan. So it shows that the PSMA enhancing lesion at the prostatectomy bed with SUV 18.1 and measured 1.3 centimeters. And in case 3, 78-year-old patient with history of prostatectomy of prostate cancer in 2007, PSA level was high, 2.3 nanogram, and injected with 18 fluorine PSMA level, and revealed no PSMA in the prostate, in the local area. Nothing in the lymph nodes. Let's have a look on the bones of the patient. This is the CT, and this is the fused images, and this is the PET scan. There is a high uptake of PSMA seen at the level of the manubrium sterni, with a maximal SUV is 6.6. And then the patient came again for follow-up 1 year after. This is his prior image, and this is this current image. As we see, there is a progression of the uptake from this year to this year in the same manubrium sterni. And so the patient came back after 6 months after giving him hormonal treatments, and this was his prior image. Here is the bone uptake, and now after the hormonal treatment, there's marked regression of the uptake in the manubrium sterni, and the SUV now is 2.9 compared with 16.9 in previously. Case number 4. 66-year-old patient with history of prostatectomy for prostate cancer. The PSA level was 2.1, and the fluorine, it's seen a PSMA level, a PSMA injection was done for the patient. And here is images. This is the CT in different different axes, the axial and the coronal and sagittal. And here is the fused images, and these are the PET scan, a corresponding PET scan for the patient. And this way, it revealed that patchy increase in the PSMA activity related to the residual prostatic tissue with SUV maximum of 5.8 measured in the right side. And continue in the pelvis, we can find as well that the uptake is taken by the left seminal vesicle with SUV maximum 3.7. So this is equal that the PSMA is perfect in localizing recurrence after treatment, though of course there is pitfalls. Everything has its advantage and disadvantage. There are some benign conditions with PSMA expression. There is PSMA negative prostate cancer, and there is PSMA PET in other malignancies. What's the benign conditions with PSMA expression? Moderate PSMA expression in osteoblastic activity is seen in osteoarthritis, degenerative changes, fibrous dysplasia, and fractures. Diffuse low uptake in Paget disease with acute and chronic inflammation association with PSMA uptake. Let's see some of the pitfalls. This is a totally normal osteophyte, and show PSMA uptake. This is an osseous hemangioma of the vertebral body, and still show uptake with the PSMA. This is the Paget disease of the left iliac blade, and still there is diffuse uptake with the PSMA examination. PSMA negative prostate cancer, a small proportion, less than 10% of prostate carcinoma, exhibit no or minimal uptake of PSMA PET-CT, reflecting low PSMA expression. If the primary tumor is not a PSMA avid, the sensitivity for detecting nodal distant metastasis disease or recurrent disease will be lower according to SESTI et al. PSMA PET in other malignancy, high intensity uptake is seen in several malignant tumor types, including renal cell carcinoma, salivary gland ductal carcinoma, pulmonary adenocarcinoma, glioblastoma multiformes, and hepatocellular carcinoma. Lower intensity uptake may be observed in wide range of tumor experience continue to evolve, and uptake has been observed in breast carcinoma, lymphoma, and meningioma. To conclude, 18-fluorine PSMA PET-CT can detect recurrent prostate cancer, neither after prostatectomy or radiation therapy. The likelihood of a pathogenic 18-fluorine PSMA PET-CT appears to be higher in patients with higher PSA level. However, the detection rate is still higher than other methods in patients with as low as 0.5 nanogram per milli PSMA level. Thank you very much.
Thank you so much, Professor Manal Halim, for this very interesting presentation. And maybe the PESMA will eliminate the category of patients with non-metastatic castrate-resistant prostate cancer very soon. Thank you so much. Now it's my pleasure and honor to introduce again Dr. Anwar Padani from